It's been more than 6 years since the bitter fight to pass the Affordable Care Act, now called by almost everybody Obamacare. So what's the prognosis? Is it making health care more accessible, more affordable, and better? Is there any improvement in the health of Americans that so shockingly lags many other countries? And here in the Southland, what are health care providers doing on their own to move medicine into the new century? Well, I've got just the folks to discuss all of that. Barry Arbuckle's here. He runs one of the region's biggest hospital networks. And so is Isabel Becerra. She runs clinics in underserved areas of Orange County. Fixing healthcare right now on Inside OC. Inside OC is brought to you by 5 Point. 5 Point is an independent real estate development company with assets under management across California. 5 Point is a proud sponsor of public television and community programming.
Chapman University, with its Center for Science and Technology, under construction in Orange, California, is a proud sponsor of Inside OC.
% of income next year or this year, that gets more significant.
Yeah. Okay. Hi, I'm Rick Reiff. Welcome to Inside OC. I'm talking about the health of healthcare with Barry Arbuckle and Isabel Becerra. Thanks again, both of you, for coming on. So let's start out for this audience. Let's tell them a little bit about you and your organizations. Barry, just briefly, who are you, and tell us about MemorialCare.
I'm the president and CEO of MemorialCare, which is a nonprofit integrated healthcare delivery system throughout LA and Orange County. We have 200 sites of care, including a large medical group, an integrated IPA, and urgent care centers, ambulatory surgery centers, imaging centers, and 5 hospitals.
And the 5 hospitals, quickly.
Long Beach Memorial, Miller Children's Hospital, Community Hospital Long Beach, Orange Coast Memorial, and Saddleback Memorial.
Okay, and I would be remiss not to mention that the Orange County Register just did its annual survey. And what were the 2 top-rated hospitals according to their reader survey?
Saddleback Memorial Medical Center and Orange Coast Memorial Medical Center.
And close-up number 3 was Hoag Hospital, which also people know about. So those were the best 3. Okay, Isabel, tell us about yourself and your coalition.
Okay, my name is Isabel Becerra. I am the CEO of the Coalition of Orange County Community Health Centers. We are a consortium of community clinics that partner together with key healthcare partners to increase access to healthcare for all individuals. We represent all of the licensed community clinics in the county of Orange. All of the clinics collectively operate 26 entities with 72 locations throughout the county. They also collectively care for 300,000 individuals and provide over 900,000 service encounters per year.
And generally these 300,000 plus individuals are those of lesser means.
We target vulnerable communities, but they are not, the community health centers are able and equipped to provide care to all. But yes, our focus is to make sure that no one goes without care based on their inability to pay. Or their inability to get qualified for coverage. Okay, and
do you also serve undocumented immigrants?
We don't track for legal status. I can tell you that we have about 10% of the total population are uninsured for various reasons.
Okay, 10% uninsured. So help me with that, because with the passage of the Affordable Care Act, isn't everybody supposed to be covered? I'm thinking that everybody that's coming into your clinics now have coverage.
I think that that's a myth that we need to break, because regardless of whether you're eligible for coverage or not, it's been very difficult to find the individuals that are eligible for coverage. And so the assumption is that the Affordable Care Act was going to be very easy to apply for, very easy to qualify for, and very quickly you'd get coverage and access. And what we found is that it's been a little bit more harder than we thought it would be. And there are individuals that are eligible for coverage but are choosing not to sign up because of the cost limitations. And then there are folks who we can't find. We've done a lot of outreach and enrollment efforts throughout the county, and they're simply not coming to the centers. We're not able to find them where we thought that we would. And then, of course, there are individuals that are ineligible for coverage. And so when you look at the total number of individuals that are not covered, it's a whole range of folks. So you can't distinctly say
who's not eligible? I thought everybody's eligible.
Well, the folks that are not eligible are, it's based on income, definitely, and also legal status, right? So it's
Okay.
not just undocumented individuals. You could be legally here, but you are earning too much money and you don't qualify, for the subsidies, or you don't qualify for the opportunity to apply for coverage.
Okay. So Barry, it sounds like there's still some wrinkles in the system here.
There were wrinkles in the system when it started, and we knew that going in. We'd like to think that Obamacare was about reforming the U.S. healthcare system, but it really wasn't. It was more insurance reform. And to that end, it did a good job. We have, about 20 million or more people that have insurance coverage today that didn't. So that's good. If we look at nations across the world, I like to say there are roughly 200 nations in the world. 40 have organized healthcare delivery systems out of that 200. Until the Affordable Care Act, 39 of them endeavored to insure every citizen. One did not, the United States. So we really needed to try to insure all citizens to have a sustainable healthcare system. So Obamacare's made good progress. Now we're working through improving quality, improving access. We like to also say that just having insurance doesn't mean you have access, because if it's expanded Medicaid, a lot of physicians don't take the low reimbursement in California, and so you'll find people that have no access.
Yeah, so tell me from your perspective on that, Isabel, the people you're dealing with, do they have more access or less access now?
I believe they have more access because the community health centers, again, take all comers, and we specifically focus on individuals that are on Medicaid and also covered California and also commercial insurance. And the clinics have done, I'm going to say, they've gone through an expansion palooza in the last 2 years. They have multiplied sites. They have achieved federally qualified health center status, which means they're able to expand their scope. So if they were only doing primary care before, they're now able to do behavioral health, mental health, vision, OB. And so the access has quadrupled, I would say, in terms of the number of access points that are available. The problem is that the rates are still not what they need to be in order for that to be a sustainable model for the clinics. And so we continue to pursue other funding opportunities and leverage opportunities so that the clinics can continue to grow.
So what you're saying is, like, Medicare only pays you so much, and that's not covering all your costs. So, and then you do have grant programs and things that you go after?
Right. The community clinics are funded primarily by Medicaid, Medicare, and the federally qualified health center status allows them to get their cost-based reimbursement, which means they're made whole in terms of what it costs them to provide care to the Medi-Cal and Medicare population. But they also seek grant funding opportunities from statewide foundations, local foundations, corporate America as well in Orange County has been very generous to the community clinics because they have been able to allow them to apply for grant opportunities and allow them to expand their scope.
So overall, from what you're doing right now, what I hear you saying is there are problems, there are things that need to be fixed, but it's better than it was.
Absolutely.
Okay.
It's better than it was.
Barry, from your standpoint, you see an awful lot of patients going through your 200 plus facilities. Yep. What's your assessment of the healthcare situation today compared to maybe 5 years ago?
I think it's improved. I think we're making great progress, and I give credit to the Affordable Care Act for kind of causing the private sector to really begin to spur some innovation. I mean, moving forward in quality metrics and aligning incentives among providers to really focus on prevention and wellness and caring for people in the right place at the right time. I mean, the system that we had for decades only paid providers when people were sick, and they paid them more when they were sicker. And that is really not where the incentive should be. And so it's making a shift. We hear these things referred to as the accountable care organizations. And that's a term that's used that means something different in every application, but generally it means that the providers are partnering with the employer or the health plan to keep the person healthy. And that's what we need to do.
Okay. And yet I read, headlines. New York Times just had an article, Ailing Obama Health Care Act may have to change to survive. And it talked about some of the problems that you've touched on that we'll talk about more. Of course, President Clinton just recently made the comment that Obamacare is one of the craziest things in the world. He clarified his remarks. He's for the Affordable Care Act, but as with his wife and presidential candidate Hillary Clinton, he wants some changes in it, and the president himself, President Obama, has said there need to be changes. But it seems like some of the things are still, we've got problems that should have been solved by now, and I mean, they should have been dealt with. This idea of some of these, Barry, let me talk about something that you know I love to talk to you about and give you a hard time. You know it's coming up.
I do know it's coming.
The charge master. And for the audience, the charge master is that thing that when you get a bill, you've been in the hospital for a few days and it's, a $50,000 bill. And then by the time the insurer works it out, it's some lower money, and you wind up with $1,000 copay on it or something. But why do we still have that system by now? Shouldn't the pricing be more consumer friendly where you know what you're getting and you don't have to go through all this crazy stuff of prices that are crazy?
I've got good news for you. MemorialCare decided a couple of years ago to completely revamp the patient bill. So we now have what we call a patient-friendly bill that only shows what their insurance company has due, how much the insurance company has paid, and then what the balance is for the individual. That's it. No more of that other nonsense that really just caused confusion, because most people wouldn't look down the page to see, forget all that stuff that we were legally required to put on the bill. Let's see how much I really owe. And they'd get incensed with what was up on the top, which is really just an archaic accounting system from the past that has just kind of continued to muddle along, even though in our organization, I'd say less than 0.1% of patients pay anything resembling that charge master.
Okay, but once in a while, and let me ask you, Isabel, because I would think you maybe see some of those folks when you have a system like this, and some people don't have insurance or whatever, they fall through the cracks. Have you had any cases like that where somebody, has a card to their name, comes in and they've got a big bill?
I think inevitably the outreach and enrollment efforts that we undertake on behalf of all the clinics allows us that exposure to the population on a one-on-one basis. So where we find the hesitancy to sign up for the Affordable Care Act is when they come with these bags of bills and they show us, I don't want to sign up because I don't want this to happen again. Look at this bill, look at that bill. I only went for something minor and I walked out with a $20,000, $30,000 bill. And so we see that all the time, and we end up having to do a lot of case management, a lot of hand-holding, if you will, through the process so that we can figure out how to mitigate those numbers, because they're alarming and it scares people away.
Have you had cases where people...
We have. So again, our staff, they do a lot of that one-on-one counseling and case management where we have to pick up the phone, call the hospitals, and ask for the charity care program. Ask for clarification about what this really means. Are they really on the hook for this $30,000, or is it that is the net amount a lot smaller? And even when it is, it's all relative, right? Because you may say, well, it's only $2,000, but if I don't have $2,000 to my name and I have to decide between paying the rent and being one paycheck away from homelessness, what are you going to do?
Yeah. And to piggyback on that and to try to reduce the number of patients that come into your clinics that have those bags of bills, we developed a concierge program where when folks have an elective procedure, we'll look and see what kind of insurance they have, see what they owe, and actually make an outreach to them to say, do you appreciate that this is what you'll owe, or that your insurance isn't, I mean, we take your insurance, but it's out of network, you're gonna owe more, is that what you want? So we let them know in advance so they can plan for it. And I can't tell you the number of times people have said, thank you, I had no idea. So people tend to buy their health care coverage based upon the premium and don't pay a lot of attention to the patient responsibility. And that includes in Covered California, which it's a wonderful program, but there's a lot of patient responsibility on some of those plans that folks don't realize until something happens.
Yeah. Where do you see this all headed, Barry? Because I know you've been doing a lot of work to try to simplify things, make it easier, but the system is still wired in so many strange ways. Is that just the American healthcare system and it will ever be thus, or do you see it moving in some direction?
I think we'll continue to improve it. Now, I think in the United States we like the interface between the private and the public. I think there's, maybe there's a movement toward an all government-run system like a lot of other countries have. But it's interesting, as I've studied healthcare in other countries, those that have socialized medicine or government-run programs, the fastest growing sector in every one of those countries is the private sector. And it's being brought about to cure some ill of the government sector, either access or quality. So having that balance in the United States, I think, is good, but you're right, we need to simplify it. And I think we're moving toward that, particularly as providers are partnering with employers or health plans or the consumer to take risk for their health care. So we're kind of all moving in the same direction, and we're integrating people together so you don't get multiple bills from multiple providers. In fact, toward that end, I think it's fair to point out that Governor Brown, just 2 weeks ago, signed legislation, I think he termed it no surprise bills. So if you go to an in-network provider and say the anesthesiologist doesn't take that particular insurance, they will not allow them to bill you out of network. They have to bill you in network. So that's a good thing. So patients in California will not get surprise bills from folks. They thought they were in network, but one of the providers that cared for them along the way doesn't happen to be in that network. So that's been, so I think we're making improvement.
No surprises. That would be a good thing. What's your sense of that, Isabel? Where are we headed? Do you think, and as you know, there's a lot of talk about in reforming Obamacare, bringing the private sector more, you know, crossing state lines and all that kind of thing. On the other hand, there's a lot of talk about single provider, you know, or the public option, which is, maybe you can explain a couple of those terms, but where do you see things headed?
I'd like to address the value-based care model that I think is the way to go, because we would be moving away from a fee-for-service model to getting paid for health outcomes and making sure that at the end of the day you're getting paid for making the patient healthier. And the community clinics are really on board with that. We are participating in statewide initiatives, the alternative payment model, we're participating in whole person care models, all of the pilots that are coming down from the federal government to the state. The community clinics are on board with making sure that they're part of that, because we the community clinics have been around for 40 plus years, in some cases 50 years, and we know what a patient-centered medical home is. We know how to make sure that patients get healthy, stay healthy, because we focus on the prevention. We do the wraparound services. We have integrated models where you have, again, primary dental, behavioral health, vision, so that you optimize that visit, because you don't know how hard it was for that family to come to the doctor today. How many buses did they have to take to get here? So we want to make sure that we capitalize on that day and have them access the care. So we would definitely, if we went to a single payer model, for example, I mean, that would mean that everyone that walked through our doors would be eligible for coverage and that we would be able to contract for that service. We want to make sure that everything that we do, that the clinics are able to get reimbursed for, and if not, then we at least contribute to the overall health and well-being of the patient, so that at the other end we can get credit, if you will, or payment for improving the health in a value-based system.
So do you like the single payer idea?
I think that that would be a preference.
Okay. Barry, do you like the single payer idea?
I don't.
Basically, we're talking about the government, just as in Canada, Great Britain, a lot of other places.
Yeah, I don't. I think it runs the risk of squelching innovation, which we've seen. I mean, much of the innovation in healthcare comes from the United States or from the private sector in other countries. I mean, India is largely government run. Most innovation comes from the private sector in India. People in Canada, government run system, when they need something really complicated and innovative, they hop across the country line. And so I like the blend of the two, not to suggest that one is better than the other. I think we need both of them. I think the government needs to put some guardrails around the private sector and then let the private sector run and try to innovate.
Okay.
I think that if we were, I like the blended concept as well, but I think if we think about shifting the resources down to the preventive side and we prevent most of the diseases that we're treating today, we would save a lot of money at the other end. I think that we need to go upstream and figure out, why are people getting sick? Why are they getting these comorbidities, these diseases that you no longer just have diabetes. You have diabetes and hypertension and congestive heart failure. Our populations are walking around with a lot of preventable diseases. We need to be focused on creating health. And I think that if we just did a shift in terms of where the resources are focused on, we would see a great improvement.
Yeah, and you said your clinics are looking at, what is it like, instead of, right now the whole system is you see a doctor for one thing and you pay for that, and then the reimbursements, of course, are all based on that. You're talking about what, you would just pay like a monthly fee or something and anything you need is taken care of?
Well, so the state is looking at a model, right, because there's been a lot of focus on how much the federally qualified health centers get paid, which is significantly higher than a private practice provider based on what Medi-Cal pays. If you're a federally qualified health center, you get paid the full cost of what it costs you to provide that service. There's a lot of scrutiny on that, and so there's talk about making that go away across the nation. California, being the trailblazer that it is, wants to look at a pilot to look at, well, let's see if we can demonstrate that we are getting this rate of reimbursement because we're actually producing quality results. We're improving health outcomes. So we're going to participate statewide in a pilot where they will take an average of the number of visits patients come in on an annual basis and take an average of how much you're getting reimbursed to see this individual, get paid that up front, and then ensure that they remain healthy throughout the year. And so you're not losing any money up front, but we're trying to demonstrate that the clinics warrant that rate of reimbursement that they're getting today. And so that's our way of transitioning or piloting how we can transition from a fee-for-service model to a value-based care.
Okay, and I see you nodding, Barry.
I think it's a fabulous idea. It's really, we're doing that same thing on the acute care side, where we're moving more toward what they call a capitated model, where here's the amount you get for this population or this patient, you're responsible for them. Your incentive is to keep them well and healthy. And that's been one of the challenges, I think, in the U.S. healthcare system, because for health plans who bore a lot of the financial responsibility, for them to invest a lot in prevention and wellness, which they knew was the right thing, cost money. They knew it would save tenfold that 5 years later, but the chances of that person or that employer being with that health plan 5 years later was not high. So they'd actually be investing to save their competitor money. So what we need are long-term contracts, like the one that MemorialCare just did with Boeing. 5 years, we're responsible for the health, the quality, the cost of a patient population over a period of time. So we're incentivized to provide all that prevention and wellness, because that payback will begin to show in future years.
Yeah, and in some ways it's starting to look like some big hospital groups like yours are kind of becoming the insurer, if you will. You know, they're taking on some of those functions, and there's talk about insurance companies merging with hospital chains and things. So all part of things that are going on in the industry.
All part of the evolution, I think.
Yeah.
I don't think we'll see insurance companies go away anytime soon, but we're certainly seeing some change.
I got to ask you about drug prices, something else. I mean, and of course, there's stories all the time. We had the EpiPen thing where, you know, the prices are being jacked up. Americans pay more, Barry, than probably anybody else for pharmaceuticals. Why is that?
Well, several reasons. One, in other countries that have developed health systems, when a new drug is introduced, they go before a committee of professionals, pharmacists, clinicians, who evaluate the efficacy and the cost and tell the drug company yes or no, or yes at this price. In the United States, it's an open market, and so to some degree we're paying for that. We also love innovation in the United States, and so we also love the newest and the best drugs in the United States. And it's also, we see a lot of publicity around why Medicare, one of the biggest payers in the country, can't negotiate with pharmaceutical companies, and that has been true since 2003. That would make some difference, but it wouldn't make, I guess, an inordinate difference. I think we just need to change some things around the way pharmaceutical companies behave and some of the regulations. A great example I like to share is insulin. It's been around for 100 years, yet there's not a generic version yet today, because the drug companies that provide insulin keep reformulating it and getting a new patent and just carrying on that patent system. There needs to be some change in that.
Couldn't the government, if the will was there, Isabel, couldn't the government change that?
I think that it could. I think it's unacceptable for individuals to be living with diseases that for which they could get drugs for and medication for, and it's out of their reach because pharmaceutical companies are making a ton of money off of that.
And again,
I don't understand.
Obamacare didn't address that. In fact, the deal was struck basically at the beginning of this to pass Obamacare to get the pharmaceutical companies on board. Is that why that wasn't addressed and we still have that situation?
I couldn't say.
You couldn't say. Barry, I'll try to get you in trouble, Barry. What do you think?
Well, I don't know if that was the deal or not, but certainly when Obamacare came together, they brought together the medical device manufacturers, the pharmaceutical companies, the hospitals, and the physicians, and brought them all in a room and basically said, here's how much we want you to pony up, and if you don't, you won't like what we do. And so there was the pharmaceutical tax, the medical device tax, Medicare reimbursements for hospitals got cut dramatically to fund for the uninsured, and so it was all kind of a bit of horse trading, which I suppose in politics is the way it works. But I agree with Isabel. I don't want to sound like a grand supporter of the pharmaceutical industry. There are some bad actors, to be sure, But I think we just need to craft some more regulation and monitor more closely what happens, because it is a travesty when someone can't afford a life-saving drug. It's simply not right.
Yeah. Okay. Well, I want to thank both of you because you are, and by the way, you should note, you're very active in the what's the state?
It's a state foundation, the California Wellness Foundation, we're working on advancing wellness in the areas of violence prevention, focusing on education, and also access and quality healthcare.
That's a state association.
It's a state foundation.
A foundation, and
right?
you're the vice chair,
I'm
right?
the vice chair.
Vice chair, and Barry, you're involved in some big groups too.
Yeah, I'm currently the chairman of the Integrated Healthcare Association, which is actually all sectors of the healthcare, looking at improving quality and access throughout California, but some of the programs that get passed in California are adopted throughout the country.
Excellent. And in interest of full disclosure, I do have to say that MemorialCare is a sponsor of this show. God bless you for that, but I do have to disclose that. So Isabel, if you think I was nicer to Barry on this show than you, at least you have a reason for that. Okay. So that's it for now. Thanks again to my guests, Barry Arbuckle and Isabel Becerra. You can watch this show and past shows by going to pbssocal.org or rickreiff.com. Also catch our shows and our post-show open mic chatter on YouTube. And follow us on Facebook, Twitter, and Instagram. Thanks for watching. We'll see you again on Inside OC. Inside OC is brought to you by 5 Point. 5 Point is an independent real estate development company with assets under management across California. 5 Point is a proud sponsor of public television and community programming.
Chapman University, with its Center for Science and Technology, under construction in Orange, California, is a proud sponsor of Inside OC.